Hi, Steph. I went ahead and pushed record.
Okay.
All right, guys. Welcome, everyone, to Stephanie Packard's DNP presentation. On behalf of Frontier Nursing University, I'd like to welcome your online audience, your live audience, your family, your friends, to witness and to see about your important healthcare outcome and process improvement project. I'd like to issue a thanks from Frontier Nursing University to the team, family, everyone. Without your support during these difficult times, her journey would have been much more complicated. For now, I ask that you all mute your mics and turn off your cameras so we're not distracting. And we'll go ahead and get started. I am Dr. Kimberly Couch, one of the doctoral clinical project faculty at Frontier Nursing University. It was my great privilege to be Stephanie's primary project faculty for the last 9 months. I'm going to miss her. Many of you know Stephanie, but I want to introduce those of you who do not know her. So let me grab
And Dr. Couch, I'm not sure if I'm recording.
I am recording.
Oh, you are? Okay, perfect.
Yep,
Thank
you. Stephanie Packard completed a bachelor's degree from Arizona State University, but soon found a love of nursing through a family tragedy. Leaving her first career, she completed the Associate of Science nursing degree through Mesa Community College in Arizona and spent over a decade working in operating rooms and emergency departments across the southern United States. She completed her Master's of Science in Nursing Education from Grand Canyon University, working in clinical education until answering the call of the mountains of Alaska. While working as a staff nurse in Anchorage, she completed her Master of Science in Nursing as a family nurse practitioner from Loyola University, New Orleans. She has been serving the state of Alaska through various roles on the board of the Alaska Nurse Practitioners Association since 2018 and currently works in Palmer, Alaska. When she's not working, she can be found hiking, camping, and exploring the last frontier. All right, Miss Stephanie, I'm going to let you take this away.
Okay. All right. I just want to thank everybody for coming. Welcome to my presentation on implementing effective care for low back pain patients in a rural multidisciplinary clinic using a patient-centered tool. So why was this project important? Low back pain is the leading cause of disability worldwide. It affects 7% of the global population, and 6% of all emergency department visits are due to low back pain. 26% of those are going to result in return visits for poorly controlled pain. And it has a significant financial impact in the United States. In 2016, it cost the US $134.5 billion, and that was 17.9% of the GDP. It's the leading cause of years lived with disability. And additionally, there's the cost of lost labor, loss of income taxes, and then the rising cost of healthcare. At our clinic, it's one of the most common complaints that comes in our door. Initial research was conducted on the treatment of low back pain, and it was guided by the 3 major professional organizations that guide our clinical practice. We started with a chart audit of 28 charts, and that revealed some gaps in practice. The Oswestry Disability Index, which is an established, validated, and reliable tool that measures pain's effect on function, was documented in 39.9% of our low back pain patients. And depression, which has a strong incidence of somatization or creating physical pain from emotional pain, depression was screened in 17.9% of our patients. And then based on clinical practice guidelines, 25% of our patients were using or were recommended to use non-steroidal anti-inflammatories or NSAIDs. 35.7% were using or recommended to use superficial heat. 11.1% of eligible patients were using skeletal muscle relaxers or SMRs. 21.4% were using mindfulness activities or recommended to use them. And 21.4% were using or recommended lifestyle modification. We started off with a survey of 34 patients, and one of the questions on the survey was, how helpful would it be to see information about the options for treating your condition? And 94.1% responded with a 4 or 5, indicating a strong desire to be included in clinical decision-making. So there are implications for not screening for depression. In 2022, a systematic review and meta-analysis found that the combination of low back pain and depression led to poorer outcomes, longer recoveries, worse pain and disability. And the American College of Physicians has a clinical practice guideline that strongly recommends for the non-pharmacological therapies for treatment of low back pain and a multidisciplinary approach. And then based on the clinical practice guidelines combined between the American College of Physicians, the Council on Chiropractic Guidelines and Practice Parameters, and the American Physical Therapy Association agreed that spinal manipulation, physical therapy, medical assessment, massage therapy, NSAIDs, superficial heat, muscle relaxers when appropriate, mindfulness activities, and lifestyle education all play an important role in the reduction of low back pain. So this project was based on the Institute of Medicine quality improvement domain of effective care, focusing on treatments based in evidence and the accepted clinical practice guidelines, and incorporating underutilized options for a maximum benefit. And it was also based on the patient health engagement model, where care is more effective when shared decision-making is incorporated. So involving patients in evidence-based care decisions improves their buy-in, and then it improves their participation, which leads to improved effective care. And it was also based in the clinical practice guidelines and a multidisciplinary approach. So the aim of this quality improvement project was to improve low back pain care by 5 points in the patient improvement score in 8 weeks. And I'll explain what that means in a moment. So the setting was a multidisciplinary clinic in Palmer, Alaska, and the clinic actually has 2 sides to the building. And on one side, there's chiropractic and massage, and on the other, there's physical therapy, and then myself as the nurse practitioner. And the patients are shared between all the disciplines. On average, we see about 125 patients daily, and anywhere between 0 to 30% of those daily patients are low back pain patients. There were various payers involved in the project, and in order of frequency, it was commercial insurance, TriWest or VA, Medicaid, Medicare, self-pay, TRICARE, auto insurance, and tribally sponsored health insurance. Then there was a pretty even split between male and female patients, and our ages ranged between 12 and 89. So we started off with a chart audit, and that gave us baseline data, and that led to the creation of a tool with 3 major interventions. These were incorporated into a rapid cycle quality improvement project that lasted 8 weeks. There were 4 plan, do, study, act cycles, or PDSA cycles, each one lasting 2 weeks. And the data was analyzed using run charts, and there was a new test of change in each cycle. There was no external funding for this project, and it was excused from IRB review. So the tool that was developed was called the Low Back Pain Care Plan tool, and it was distributed amongst the chiropractic, the physical therapy, and the nurse practitioner patients. And it was given out at 1 appointment during each PDSA cycle. And so a patient that was with us from start to finish could potentially fill it out 4 times. So depression screening was done via the PHQ-2, which is a reliable and validated tool, and it has a maximum score of 6, and it's considered positive at 3. Then pain and disability screening was basically what guided the aim of this project, and that was measured via the low back pain disability score. And that score was actually a combination of the traditional 0 to 10 numeric pain score and the Oswestry Disability Index, which has a max score of 50. And that led to our improvement score. The improvement score was the difference between the initial and the final disability scores. And then we also measured patient readiness screening, and that was done via a patient options grid, and that had a maximum score of 45. And the therapies that were listed on this grid were the therapies that we have available in this clinic, and all of them were based on those clinical practice guidelines. And patients were able to rate their interest in that particular therapy on a Likert scale of 1 to 5. And then we had a balancing measure, which was staff stress levels, and that was measured on a 0 to 10 scale, of 0 being no stress at all, and 10 being I'm barely hanging on. The data that was collected from the field notes, surveys, and components of the low back pain care plan tool, and aggregate data was compiled every 2 days. Means were plotted on a corresponding run chart and assessed for the impact of the intervention. And that was done via runs, shifts, and trends. And each one of those drove the new test of change. So the aim, essentially effective care, was measured as that improvement score from baseline. And it was derived from comparing the initial and final low back pain disability scores. The process measures were the completion rates of the tools, and the outcome measures were basically measuring the impact of the intervention. And then tools were recorded and collected daily, and that helped improve the accuracy. And then the balancing measure was, of course, those staff stress levels. So qualitative data was collected from field notes, team meetings and huddles and surveys, and they were assessed for emerging patterns and themes. And then quantitative data was taken from the scores of the tool. And then aggregate data was assembled into summary charts and assessed for variation. And then the means were plotted on run charts, which were updated every 2 days and analyzed for statistical significance via those runs, shifts, trends, and then the identification of outliers. This is a really busy slide, but basically what we're looking at is a chart comparing baseline to mid-project to final cycle results. Wherever there's a blank, that's just due to a lack of baseline data, and that's mostly due to the nature of the gaps that we had and then the development of the tools. The project evolved over time as the data guided new tests of change in each cycle. And the most successful intervention seen here in yellow was our depression screening with the PHQ-2. Our completion rate steadily increased from 17.9% at baseline all the way up to 96.7% in the final cycle. And then our depression positivity rate normalized over time. So interestingly, the patient options grid completion rate seen in orange, or it might look red on here, it decreased over time. And we think that that might be due to form fatigue. Our staff stress levels had a baseline score of 4.8, and then the final mean was 5.6. So it did actually increase. However, only 9.1% attributed it to the project itself. And then most importantly, our aim was to improve effective low back pain care by 5 points in 8 weeks. And at our final data point, we reached 4.3. So there were 166 total tools that were completed, and out of those, we had 45 repeat patients. We had to exclude any that didn't fully complete the pain score or the Oswestry. And so what we were left with was 35 patients, but that also included fibromyalgia patients, acute on chronic pain, and new injuries. But you can see with this yellow arrow, in those final 2 PDSA cycles, there was an upward slope of consistent improvement to that 4.3. And again, that patient improvement score is basically the final low back pain disability score minus the initial low back pain score. So the first intervention was depression screening, and that was a new process for most of the clinic, especially the non-medical providers. And it started with the DNP patients and it spread in PDSA-2. Our first and most successful test of change was education on male depression. And our male patients were 20% less likely to complete their depression screening. And our initial completion rate was 68.4% when we spread it clinic-wide. And then after we implemented that education series, we spiked to 92.9%, and that's a tremendous increase. It led to a better understanding of our patients and their needs and our mental health in our clinic. And that led to more patient-centered conversations. And our cumulative clinic positivity rate was 23.2%. And that's actually a lot higher than the regional rate of 17.4. And that indicates a correlation between pain and depression, and that's really consistent with the literature. The effectiveness of identification of depression and treatment and referral ties into that steady increase of the patient improvement scores in those final 2 PDSA cycles. The second intervention was that pain and disability screening, and that also started with the DNP patients and spread clinic-wide in PDSA-2. And that low back pain score was, again, that combination between the patient's numeric pain score and the Oswestry score. Any tool that was missing one of those had to be excluded. So 85.5% of the patients that received the tool fully completed both components. So distribution rates decreased in PDSA-2. And so our test of change was team building exercises such as contests. The staff members that collected the most fully completed tools each week and then overall received prizes. And it helped, but staffing changes caused another decrease in the distribution. We did have a goal to keep the low back pain disability score at 23 or less, and that translates to mild to moderate pain and a low functional disability. And we successfully remained under the goal in the mild disability range with all of our patients. Pediatric scores, not super surprisingly, remained the lowest. Their cumulative mean was 13.7. And early middle age, which is ages 35 to 44, had the highest scores with a cumulative mean of 20.2. So pain and disability screening was successful in capturing patient acuity, and it gave us a barometer to make effective changes to care plans. And that led to that increase in improvement scores. The third intervention was patient readiness screening, again, starting with the NP patients and spreading clinic-wide in cycle 2. And we had a steady decrease in the completion rates over the cycles. Started at 100% in cycle 1, and then we ended at 91.8% in cycle 4. And that we attributed to form fatigue. Anecdotally, we heard a number of patients saying, oh, great, I have to fill this out again. So that's kind of where that happened. Interestingly, early middle age, who had the highest rate of disability, also had the highest level of interest in their care. And across all categories of patients, there were 4 items that had the lowest rate of interest, and that was the muscle relaxers and NSAIDs, mindfulness activities, and lifestyle education. But SMRs and NSAIDs are not safe for everybody, and they're not appropriate for everybody. So mindfulness is, however, safe for everybody. And so as a test of change, providers were encouraged to have mindfulness conversations with their patients and discuss things like yoga, meditation, prayer, and journaling. And there was a handout that was available for patients to refer back to. There were 12 patients that had documented conversations, but I think it's likely that more of those occurred than were documented just based on conversations with providers. Overall, you can see on this chart that the scores really didn't fluctuate for readiness, but the targeted interest in mindfulness did. And at our final data point, 46.3% of patients rated their mindfulness activities on a 4 to 5 on that grid. So this increase in patient engagement occurred alongside the increase in the patient improvement scores. So our aim was the mean improvement score of 5, and at our final data point, we reached 4.3. So that really indicates an effective reduction in pain and disability. Our patients were engaged and they were interested in their care, and that's evidenced by the net increase in the patient engagement scores. And 10 participating patients completed a post-project survey. 8 of them reported that the project made them want to make changes to improve their health. 3 reported that the project helped them understand that they actually have depression symptoms. All of them stated that the project helped them understand what treatments are available in our clinic. And every one of them reported that they felt that their provider supported their treatment choices and valued what was important to them. There was a general ease of implementation and overall success of the project. So how do we interpret the project results? There is a correlation between depression and low back pain, and that's consistent with the literature. And by addressing depression, we addressed a contributing factor of low back pain, and that translated to effective care, an underutilized option for maximum benefit. PHQ-2 depression screening improved effectiveness of care by providing patients with necessary resources. And as a result of this project, we placed National Suicide Prevention Hotline wallet cards in the bathrooms for patients to take discreetly. And we've consistently had to replace those cards. So I know that we're making a difference to people. Pain and disability screening was key in assessing the effectiveness of care. 45.8% of surveyed staff reported that screening provided them with a better understanding of patient acuity. And the clinical practice guidelines support repeat screening to track improvement over time or its lack. And repeat screening allowed us frequent adaptation of patient's care plan, and that led to that greater improvement score. There was a decrease in the options grid completion, and that did lead to a decrease in data that was available for us. But, and that was an unanticipated outcome, but I don't see that as an issue moving forward because there's not a need to consistently screen for that. The increase in mindfulness teaching does correspond to an increase in improvement scores, and that indicates that mindfulness helps to manage chronic pain and improve coping, which is consistent with the literature. There were some limitations to this project. We have really unique clinic logistics. There are 2 sides of the building, and that impedes communication sometimes. And then there's potential for sample size bias. We did have a small group of patients that were part of this project. And then there's confounding factors such as fibromyalgia. Those patients have good days and bad days, acute on chronic pain, and then new injuries, which does change the outcomes. There were also several staff COVID infections and a natural disaster at the onset of the project. Everyone's giggling, that was fun. So this picture is just an example. We had hurricane force winds with sub-zero temperatures, and that led to widespread damage. And we had to reschedule a lot of our patients. And then patients also regressed a little bit during that time from the physical labor that was required to repair their property. And then repeat patients frequently failed to fully complete the tool, and that led to lower than anticipated usable data. And our electronic health record has inconsistent use across the clinic, and the reporting features aren't very useful. So there was a need for manual counting of the number of low back pain patients seen, and that was pretty unreliable. But to mitigate some of these limitations, we increased training. There was team building exercises, the implementation of Microsoft Teams for better communication across both sides of the building, and then in-person huddles. So the aim of this quality improvement project was to improve effective low back pain care by 5 points in the patient improvement score within 8 weeks. And our improvement score at the final data point was 4.3. There was an overall low, median, low back pain disability score and an overall high level of patient engagement. This tool would serve as a great template for low back pain treatment and referral, really in any clinic that sees low back pain patients. It has a very low cost. It was really just the cost of paper and ink. And it's sustainable easily because it's easily incorporated into new patient or new injury paperwork. So the recommendation would be to continue the use of the tool, and the spread of the tool could be instrumental in providing effective patient-centered care across our state. And these are our references. And really quickly, before I open things up for questions and discussion, I do need to express my gratitude. These are just a few of the faces of people and critters that were instrumental in this project, and I can't express enough appreciation for their support. Not pictured are so many more wonderful people that made a huge impact, but many of them are sitting here with me today or logged on remotely. I want to thank everybody at the clinic for their support and dedication to our patients. Dwayne, who is the most supportive boss I've ever had. Joe, who's my right-hand gal and I couldn't possibly survive without. Emily, my medical assistant, who made certain that every patient that walked in our side of the building had a care plan tool. And Dr. Couch, who answered panicked emails and text messages at all hours on all days and kept pushing me to be better. My DNP group, who kept me sane and encouraged me. And my family and friends, especially my incredible husband, who were my cheerleaders. Thank you. And then, of course, this is our HR department. So at this point, I would love for everybody who's joining us remotely to turn on their cameras, turn on their mics for discussion, questions, comments, concerns, considerations, feedback. Anyone?
That was great, Stephanie. This is Shelley. Hi. Such an important thing to be able to really link all those different resources. I was wondering, since there was that issue with form fatigue, is there a way to continue doing this screening and doing this shared decision making in a way that doesn't lead to the form fatigue, but also does continue the project so that patients have access to that?
Yeah, so since we were doing this every 2 weeks, that was a lot for a lot of our patients, especially, when you're in pain, you don't want to be stuck filling out another form. And so I think that if we were to do it in new patient paperwork, and then maybe at a reassessment every few months or so, and then if there's a new injury, we can incorporate it again. So I think that that would decrease the form fatigue, but also allow patients an opportunity to revisit the services that are available and the treatments that they have. Okay, so I do want to ask the providers here, how do you see this information affecting your practice moving forward? Yeah.
Well, I thought the depression screening was super helpful. We had that one young man, and I don't know if I ever followed up with you on that, but I ended up asking him how his vitamin D levels were. If he was hadn't been taking it.
Okay.
And we got him on about 2,000 IUs a day, and came back a couple weeks later, and he was feeling a lot better, just mentally. He looked a lot better.
Yeah.
So I think including maybe a questionnaire like that would be super helpful, just because it's just 3 questions quick.
Yeah, it's super easy. It's just the PHQ too. So yeah, it's a good starting point. Thank you. Yeah. For those of you that may not have heard that, we had a mutual patient that it turns out he had really, really low vitamin D levels. Because we asked those questions, we were able to correct that. Anybody else have any thoughts on that?
That does seem quite relevant since.
Yeah.
That does seem quite relevant since Alaska is quite high for mental health and
Yeah.
seasonal effectiveness disorder, that it makes sense that we would do it in all practices of care, not just medical side. And especially since it does correlate quite closely with pain and self-pain.
Yeah.
Makes sense.
Yeah, so the response was, especially in Alaska, where we have very little sunlight during the winter months, we notoriously have really low vitamin D levels. So, and seasonal affective disorder is a big thing. So checking for that is important. So that kind of leads into the next question was, how has our strong correlation between depression and low back pain affected your care with your patients? If it has.
I think for myself, it was really eye-opening to see the number of people that were positive for depression. And so once that was brought to my attention, it's that people are a lot more. I think as practitioners, we sometimes fall into certain patterns. And so it was just eye-opening to see that some of the people that maybe did badly after chronic pain, maybe has some other etiology playing out, and maybe was an underlying spot there. So I really enjoyed that. I also really liked I really enjoyed seeing what people were interested in. As again, we run in on chiropractic or nursing or physical therapy. We assume that the people are here for this service and maybe this service only. And when we put that out there, there's a lot of people who are like, yeah, be interested in learning about how a nurse practitioner could help me with pain management, or how a physical therapist could work with the chiropractor, how massage therapy or how lifestyle interventions could achieve better health for the patients. Because ultimately they're here for their health to be improved. And they don't really care if it's through chiropractic, massage, physical therapy, they just want to feel better. And so it was really eye-opening for me to see how people were seeing all the other things that we had to offer here at the clinic.
Yeah, I think it was really interesting, especially because we get so many patients that they might be a referral from an orthopedic provider after surgery to come do physical therapy. And then they don't realize that, oh, I can also get a massage. I can talk to a chiropractor. I can see a nurse practitioner for other pain issues. And so I think it was really nice to bring that to their attention.
I don't mean to hog the time, but I also had a lot of patients really enjoy the fact that once they were maybe referred from me to somebody else, I would visit with those other practitioners and say, hey, I spoke with Stephanie, and we both came to the same conclusion that this is what we need to do moving forward. And they really, I could see, enjoyed that there was two brains working on the case rather than one. And I think it was reassuring for people to see how the office works as a team as opposed to just individuals. Yeah, I think it was really helpful. It gave us a lot of continuity of care, and that multidisciplinary approach, that collaborative approach, that I heard that comment many times as well, where a patient said, you know, I really, really appreciate how you're really coming together and discussing my case and what's going to be the best for me. So it was a very positive reception from that.
From a patient perspective, having a care team that talks to each other rather than being forced to be your own advocate quite often is quite relieving, especially in our insurance-focused medical community that it is, where it takes some of that relief off of the patient so that they can focus on themselves rather than having to be your own agent and advocate. On a separate related note, we would get patients that were referred for orthopedic injuries, but then due to the accessibility devices that they would need, like a boot. For example, we have a patient who came in a boot, and while they were referred for their foot problem, low back pain did become another problem because their gait was thrown off.
Yeah, absolutely.
So having this multiple disciplinary practice did allow us to treat those things faster than if they had to go back to their ortho to get a referral to somebody at chiropractic who would then refer us to here. So that was a big asset to our patients.
Yeah, I think it did give us a more holistic approach to our patients and really looking at the big picture from multiple points of view.
Well, Stephanie, I want to tell you, this is a fabulous presentation, and everyone, congratulations for a great discussion as well. And you guys can continue this when we're all done. I understand there's a party and food involved. So on behalf of Frontier Nursing University, I'd like to thank your team, your leadership for participation in this project, your family support, and your commitment to quality improvement. It's not easy, but look at your wonderful results. And you were challenged with COVID and natural disasters, and you overcame and conquered. And that is something to be proud of and to celebrate with joy. I'd like to congratulate the future Dr. Stephanie Packard, who upon successful completion of all didactic and clinical requirements of Frontier Nursing University's Doctor of Nursing Practice program will have demonstrated mastery of the DNP essentials as defined by the American College of Nurses. Stephanie, fantastic job. Everyone, mics open, turn them on. Let's give her a round of applause. Well deserved, girl.
Yeah. Congratulations,
Great job.
Fantastic. Really proud of you, girl. It's just awesome. So happy. All right, I'm going to release your online audience so you can get the food.
Okay, thank you.
All right.